All right, great. Well, thank you so much for coming out, everybody. It's amazing to see such a turnout. I'm really, really impressed that so many of you are willing to take an evening, and it really speaks to the saliency of the issues right now and how far along we are in the national debate and how close we are, how tantalizingly close. Helen is always a hard act to follow. We've done this back and forth a number of times, and I can say that the audiences are growing, which means we're getting closer. What I'm going to be doing tonight is really trying to address some of the other issues that Helen didn't have a chance to talk about, and then we'll get a chance to do our sort of back and forth in a few minutes after we've all had a chance to speak. I just want to start out by sort of recalling the sort of larger sets of goals that we have for our health reform initiatives. So Helen spoke very passionately about the issue of the uninsured, and it's certainly a national disgrace having 46 million uninsured people, and for the Obama administration, and for I suspect many of you in this room, that is the primary goal of health reform, is to try to reduce the number of uninsured. For many other people in the country, that is sort of an important, laudable goal, but even more important than that, which is driving the employer community, many conservatives to back some type of health reform right now, is to think about the long-term rate of increase in healthcare spending. So I imagine that most of you have seen some figure similar to this. This shows the percentage of our GDP which is being spent on healthcare over time. So as we go back to early 1960s when Medicare and Medicaid were initiated, we were spending about 5% of our GDP. That crept up to about 8%, and people said, oh my God, this has got to stop, this can't continue. What are we ever going to do? Well, we're double that now. We're about 16% of GDP, and projections are that if nothing changes, we'll be up 25% or more not too long. Is this a good or bad thing? Well, it depends on where you sit. We're certainly spending a lot of money on newer technologies making us healthier. But we also think that we're spending a lot of it very inefficiently as well, and we could probably bend this curve down if only we could figure out how. And Steve's going to be talking more about about how. But underlying this is sort of one of the key reasons why we're actually seeing the number of uninsured creeping up over time. People are often surprised to see how expensive health insurance is today when you add in the amount of health insurance premiums that your employer is paying on your behalf. So a standard employer-based health insurance policy today costs around $13,000. Okay. Median income in this country is only about 4 times that. Right? So this is getting really, really expensive, and so more and more people just simply can't afford to buy insurance. Okay, so how are we proposing to look at this? The main reforms in Congress today, as Helen has talked about, would retain our current employer-based system. They're not really blowing up this system. There would be major changes in financing and help for uninsured folks, but it wouldn't have wholesale changes to the way that we're insuring people in this country today. They would add certain options like this purchasing pool, maybe a public option. There would be additional subsidies for low-income people, small businesses, new regulations, as Helen has talked about. And then 2 of the most controversial items, which I think are potentially quite important, are the idea of an individual mandate and that of an employer mandate. So let me just speak about those for a couple minutes, very generally. So individual mandate. Many people argue that if we really want to achieve universal coverage, we're going to have to do it by requiring everybody to have health insurance, that there are enough people who would select themselves out of the system that we wouldn't really get quite there. Now, we can argue about that. Some people say, well, we could get pretty darn close. But when you talk to the insurers, they will argue that we can't actually have a system that's functioning very well if we allow people to select out of this system themselves. It's going to lead to reduced risk pooling. It's going to lead to all sorts of distortions in premiums. Now, on the other side, of course, you have the standard libertarian objection to requiring anybody to do anything. And then we have the concern that if you really want this to be binding, you can't tell a low-income person who's at the poverty line to pay for a health insurance policy that's going to cost $13,000 a year for their family. You have to have sufficient subsidies in the system to make this credible and workable. So how do we do that in the bills that are before us now? Well, President Obama during the campaign suggested, well, let's start by mandating insurance coverage for children. They don't have a choice. Let's make sure that we're covering them. Adults can be left on their own. In the bills that we're looking at in Congress now, they're actually thinking about having a more binding individual mandate, although there are safety valves. So if it turns out that available insurance becomes too expensive, then we will exempt people from that mandate. So in the Baucus bill in the Senate Finance Committee discussing now, if the premium is more than 10% of your income for the available plans in the market, then you would be exempted from buying health insurance. So that's great. We're not throwing them in jail, but they're still uninsured. You could think about having stiff penalties for buying insurance later. So this is the tack that Medicare Part D took, and it did a pretty good job at getting everybody into the system. You could tax people who are uninsured. You can say, okay, you have the choice of being uninsured, but we're going to tax you so that you're contributing into the system. So again, Baucus's bill is suggested initially having a tax of about $750 or $950 a year for a higher income person. They're sort of messing with these amounts right now because there's been some pushback. Baucus has also suggested that, well, if our insurance is too expensive, then we would provide subsidies by capping the amount of premiums that you're required to pay at 13% of your income. Now, many have suggested that that is just wildly too high, and that ought to be about half that amount. Now, this is a delicate political balance. Even at this 13% level, estimates are that we would have maybe 25 million of our currently uninsured people who would get covered by the system. That's a pretty darn good improvement. It doesn't get us all the way. We would still have a few tens of millions of people uninsured. But this is an exercise in compromise right now. Okay, how about the employer mandate? So why do we want to have an employer mandate? Well, on one side is the political salesmanship. We can talk about having shared responsibility. So individuals need to contribute, the government needs to contribute, employers need to contribute. Okay, that sounds good. And from a theoretical perspective, we could also argue that if you don't have an individual mandate, then an employer mandate is actually going to raise money for the health insurance system in a more efficient way than tax revenue. Okay, so whenever you raise money, taxes, in order to finance health insurance, it's going to create distortions in the labor markets and going to create distortions which, average estimates are that maybe for every dollar that we raise to cover an uninsured person, it costs our economy $1.25. Right? If we instead force employers to withhold money from people's paychecks to pay for their health insurance, then we don't have to incur those costs. And so it's more efficient to have an employer mandate. Right? So that's part of the theory, about economic theory, about why we want to have an employer mandate. But at the same time, people have argued that, well, then maybe they're countervailing distortions. So these employers may be hurt if they have to pay for health insurance. Now, economists have argued that, well, actually, when an employer pays for health insurance on your behalf, they're not actually paying for it. From an accounting perspective, it's coming off of they're writing the check. But the incidence comes from the worker in terms of lower wages. Okay, and that doesn't happen immediately, but over time, labor markets adjust and individuals' wages go down. This is easiest to see when you think about labor management negotiations over wage contracts. It's very clear in those contexts that you're trading off your wages for your benefits. Okay, so if an employer is paying for health insurance benefits, that's coming out of the pocket of the individuals.